introduce. Our webinar today, organized by the International Pharmaceutical Federation, is titled Leveraging Pharmacists for Tobacco Cessation, New Policy Tools, Evidence, and Success Stories. And we are broadcasting this event directly live from the World Health Assembly in Geneva, Switzerland. As most of you have seen before we actually started this session, FIP has launched a new campaign, Think Health, Think Pharmacy. This is a new global campaign launched by the International Pharmaceutical Federation during the last days to raise awareness of pharmacies as places of primary healthcare provision and to advocate for pharmacists as healthcare professionals. And despite substantial and recent advancements in pharmacy practice, now is the time to make bigger push for more professional recognition and the additional pharmacy services that go with that. So this campaign is an important strategy to advocate for our members and the wider profession around the world. And this will be a long-running campaign sustained through regular releases of new campaign materials and other activities. Today is the World Tobacco Day, and what a fantastic opportunity to highlight the need for tobacco and nicotine cessation. There are 1.25 billion oral tobacco users around the world, and 60% of them want to quit, but only around 35% of the world's population have access to comprehensive tobacco cessation services. And given the global prevalence and burden of tobacco use, particularly as a risk factor for noncommunicable diseases, it is important that the services provided by pharmacists in this area are expanded and consolidated. At today's event, FIP will launch a global intelligence report on pharmacist-led tobacco cessation services. And a joint statement between the World Health Organization and the International Pharmaceutical Federation will be presented, and a call to action on the role of pharmacists in tobacco cessation and examples of successful pharmacist intervention and services in tobacco cessation will also be presented, along with findings from a survey and a systematic literature review. And I would also like to introduce myself. My name is Lars-Åke Söderlund, and I'm one of the vice presidents of FIP. And it's a great honor and pleasure to co-chair this event today with Professor Long Chao Ming, Associate Dean for Research and Postgraduate Studies, School of Medical and Life Sciences at Sunway University in Malaysia. And for this event, we also are joined by a panel of fabulous speakers. And I would like to sincerely thank each and one of them for taking the opportunity and time to prepare their presentations. Our distinguished speakers today are Mr. Paul Sinclair, the President of the International Pharmaceutical Federation, Dr. Vinayak Prasad, Unit Head, No Tobacco, Department of Health Promotion, the World Health Organization, Dr. Hussam Al-Salamat, Chairperson of Continuous Professional Development, CPD Committee, Jordan Pharmacist Association in Jordan, Mr. Rah Vaidia, ex-chairperson and vice president of the Indian Pharmaceutical Association from India, Mr. Antonio Rodriguez, Director, Evidence and Health Solutions, National Association of Pharmacies in Portugal, and Ines Nunes da Cunha, Shirley Mailiante, and Farah Akkad as co-authors of the new intelligence report from FIP. Most welcome, all of you. It's indeed a great pleasure having you all with us today. And as you can see on this slide, we have some announcements to prepare for you. Like some housekeeping rules. This event will be recorded, live streamed on FIP YouTube, and the recording will be available at events.fip.org. To all those listening in live, please feel free to send your questions through the Q&A box provided, and we will do our best to manage all the questions, so at the end, we will be able to address those questions. And you're welcome to give us feedback on webinars at fip.org. And I would also like to take this opportunity to promote the benefits and membership with FIP, including events and webinars. FIP is the global body representing over 4 million pharmacists and pharmaceutical scientists. And if you are a pharmacist or a pharmaceutical scientist and you would like to become a member, please register on the FIP website, fip.org. Today, the Turkish Pharmacist Association, one of the members of FIP, offers a Turkish translation available on Zoom by clicking on the translation icon at your screen. Thank you so very much for this kind support. Now over to my co-chair, Long Ming.
Thanks, Lux. I'll just quickly walk you through, as mentioned by my co-host. So the listed are the programs for today. First of all, we have an opening remark by our esteemed FIP President, Mr. Paul Sinclair, and followed by presentation of the joint WHO-FIP statement on the roles of pharmacists in tobacco cessations by Dr. Vinayat. Then followed by presentation on selected findings from the FIP Global Intelligence Report on pharmacist-led tobacco cessation services by Dr. Ines, Dr. Shelley, and also Dr. Farah. And lastly, there will be brief country updates, roundtable discussion, and Q&A, focusing specifically on topics related to implementing tobacco cessations, policy implications, facilitators, challenges, and country-level experiences. Our panels consist of Mr. Paul Sinclair, Dr. Vinayat, Mr. Usam, Mr. Raj, and Mr. Antonio. And then we will wrap up today's sessions in about 1.5 hours. Next, please. Okay. Let me just quickly brief you on today's learning objective. So all attendees will learn about the importance of leveraging pharmacists for tobacco cessations and the new WHO-FIP statements on this topic. The second learning objective is learn the findings from the pharmacist-led tobacco cessation services, specifically on the Global Intelligence Reports. Third, examples of countries with tobacco cessation services provided by pharmacists will be presented. And then lastly, how pharmacists can be further involved in tobacco cessation intervention services in their home countries, and including the jurisdictions. Over to you, Lux.
Thank you so very much, Long Ming. It is now my great honor and pleasure to welcome the President of the International Pharmaceutical Federation, Mr. Paul Sinclair from Australia. Welcome, Paul.
Thank you, Lars, and welcome everyone. And it's a real pleasure to be with you here tonight or during the daytime where you might be at some other location. On this very important webinar, we will launch the joint WHO-FIP statement on the role of pharmacists in tobacco cessation. And also we'll look at how pharmacists and their skill set can be leveraged to help people in the goal for tobacco cessation. Tobacco use is a major public health problem that imposes a heavy burden on individuals, communities, and economies around the world. It is one of the leading preventable causes of death worldwide, contributing to a variety of diseases and a leading cause of premature death. Pharmacists can contribute to and support the cessation of tobacco and nicotine use in a various numbers of ways, including health promotion and education, by fielding inquiries about tobacco and nicotine use, assessment of readiness to stop using tobacco and nicotine, by partaking in structured tobacco and nicotine cessation programs that include tobacco user monitoring and management, engagement with prospective quitters, support for behavioural change that's required to quit nicotine and tobacco, pharmacological interventions, including prescribing medicines, monitoring and optimising treatments, referral and interprofessional collaboration, by having an influence on public health policies at a local and state and federal level, empirical research and clinical trials. It's most important where we can to be involved with these, and also at the to look at the economic evaluation of interventions that pharmacists might make in smoking and nicotine cessation. I cannot stress enough the importance of the collaboration with the WHO in this area, and particularly the acknowledgement and support of WHO of the role of pharmacists in tobacco cessation through the new Statement of Policy. This statement encourages national tobacco control programs and governments to leverage pharmacists to provide comprehensive tobacco cessation services. Community pharmacists are increasingly taking on additional roles in primary healthcare and the prevention and management of non-communicable diseases and their risk factors. Tobacco use and nicotine dependence are major risk factors for several chronic diseases, and therefore supporting people to live tobacco-free lives is essential not only for people to achieve better health, but also for health systems to remain sustainable and evolve towards universal health coverage. Thank you, Lars, and I look forward to a number of all of the presentations, in fact, that we'll see tonight.
Thank you so very much, Paul, for this introductory statement. Considerable progress has been made over the past 2 decades in reducing the prevalence of adult tobacco use. And between the year 2000 and 2022, the prevalence of tobacco use among people aged 15 years and over reduced from 32.7% to 20.9%. However, there are still 1.25 billion adult tobacco users around the world. And supporting current tobacco users to quit as a key component of comprehensive tobacco control approach to reduce the prevalence of tobacco use is particularly important, since 60% of the current 1.25 billion global adult tobacco users want to quit, but only around 35% of them have access to comprehensive tobacco cessation services. Next slide, please. The Non-Communicable Diseases Program, NCD's program, aims to deliver FIP's commitment to the WHO's Astana Declaration on Primary Healthcare with a focus on NCDs. In 2018, FIP signed the Astana Declaration on behalf of the entire profession to ensure pharmacy contributes to the delivery of universal health coverage by 2030 through its role in primary healthcare. And the primary healthcare agenda highlights the need for the incorporation of health education, disease preventive measures, early screening, and treatment services in the management of NCDs. The FIP Non-Communicable Diseases Program includes the FIP Practice Transformation Program on NCDs, which we have been developing since 2021. And I encourage you all to take a look at this program. It is an extremely valuable tool for pharmacists and other healthcare professionals. The FIP Practice Transformation Program on NCDs aims to provide tools, but also strategic support to FIP member organizations to develop and implement primary pharmacy healthcare services that can have a sustained positive impact in the prevention, screening, management, and treatment optimization of NCDs for improved patient outcomes and improved efficiency and sustainability of our health systems. While the program has a particular focus on low and middle income countries, it also encourages implementation by countries on all income levels, since the goal of optimizing NCDs management and reducing the burden of these diseases are global imperatives. The program initially focused on 5 disease areas, including cancer, cardiovascular diseases, chronic respiratory diseases, diabetes, and mental health, but also the risk factors for NCDs, such as tobacco use. The program has been expanded to include prevention of NCD risk factors, particularly in the area of tobacco cessation. And to facilitate this, FIP published a handbook and a knowledge and skills guide to equip pharmacists with the necessary tools to provide effective tobacco cessation services. This FIP holding statement, launched last year, is intended to inform governments and policymakers, FIP member organizations, pharmacy academic institutions, and individual pharmacy professionals of the position of FIP on the use of electronic cigarettes. The statement has a focus on the health and economic impact of e-cigarette use and the contribution of the pharmacy workforce to its elimination. FIP has also initiated work at country level in Jordan and India in collaboration with our member organizations and the World Health Organization. Both great examples of collaboration and also showcasing the need for collaboration. I also want to take this opportunity to highlight some current work from FIP on tobacco and nicotine cessation. First, we have pharmacist-led tobacco cessation services, a new global intelligence report launched today to mark the World No Tobacco Day. Secondly, the joint statement between the FIP and the World Health Organization on the role of pharmacists in tobacco cessation, launched today as well to mark the Day of World No Tobacco. Third, translations of the handbook and knowledge skills guide to Arabic, Chinese, French, Spanish, and Turkish. This will be completed during the year, and I think at the moment only one of these translations are missing. And the fourth one, the FIP statement of policy on the role of the pharmacist in establishing a future free from tobacco and nicotine dependence. The fifth one, tobacco cessation, supporting work at country level in collaboration with the World Health Organization, as well as training modules, for example, in Jordan and India. And six, we have a series of regional online events planned to empower pharmacists to support the tobacco cessation. This was happened during June and July this year. It's also my and all of the program publications, event recordings, of course, and other resources and tools are available on the FIP microsite on NCDs, ncd.fip.org, ncd.fip.org. And it's now my pleasure also, to hand over to my colleague, Long Ming. Yes, Long Ming, please continue.
Thank you very much. I'm delighted to introduce our first speakers, Dr. Vinaya M. Prasad, Head of WHO No Tobacco Unit, or also called Tobacco Free Initiative. He is the lead for Global Tobacco Control Program in WHO and has successfully scaled up the Global Tobacco Control Program in the last couple of years. More recently, he has launched the Cessation Consortium to bring in non-state personnel and the Tobacco-Free Farms Initiative in Kenya and Zambia, bringing in World Food Programme, Food and Agriculture Organizations, and other United Nations partners. Dr. Vinaya joined WHO TFI in December 2009. Prior to joining WHO, he worked with the Government of India in various capacities in the Ministry of Health and Ministry of Finance. An expert in trade, taxes, and anti-smuggling and in public health, he wears multiple hats. He was invited in 2006 to help WHO developing a template protocol on illicit trades in tobacco products that serve as the basis for WHO Framework Conventions on Tobacco Control, or better known as FCTC, on intergovernmental negotiations on the protocol. Dr. Prasad holds a master's degree in business administration with a specialization in public service and a bachelor's degree in medicine and surgeries. The screen is yours, Dr. Prasad. Thank you.
Thank you. First of all, happy World No Tobacco Day to everyone. And thank you to Mr. Paul Sinclair, the President, Lars, Professor Long, all of my panelists and colleagues, ladies and gentlemen. I'm glad to be here on behalf of WHO. It's an important milestone when we engage partners and see how we can expand our collaboration. And what better day to talk about it than World No Tobacco Day, when we are trying to protect our children and youth from the predatory tactics of the industry, which is what the focus of this entire campaign is. Next slide, please. So just to reflect, because I'm sure many of you have not heard of some of these technical abbreviations and jargons, WHO's 77 years is old, but it doesn't have any big set of treaties like many other organizations like ILO. The first one, which was negotiated within WHO as a treaty, was the one on tobacco, which is called the Framework Convention on Tobacco Control. It's a treaty which was negotiated and came into force in 2005. It's 19 years old. And the second treaty, which I'm sure all of you are hearing about, is the pandemic treaty, which is currently ongoing and where the current World Health Assembly is seeking to expand to the IHR, the regulations, and then work on the specific elements which are still red flagged. So the relevance of the treaty is that it put binding obligations on countries. So Article 14 of this FCTC talks about the countries that are party to this treaty. We have 183 countries that they will make available support to the tobacco users to quit. But it actually quite an orphaned measure, because not many countries have invested in it because they believe it's not cost effective, and two, they think it is an individual's choice and they need to take that decision. But what we are seeing is that the global target, which is an SDG target of 30% reduction, cannot be achieved if we cannot help the current tobacco users to quit. We have 56 countries on track to achieve that reduction target, and we have 150 countries which are trending down. But still, we have 1.25 billion. In absolute numbers, we have 19 million less from the last report, 19 million less smokers. But 1.25, and I've already heard from Lars, he's already put those numbers in France, 60%, that's 750 million people want to quit, and less than 350 of them have access to quitting solutions. So there's a lot of opportunity out here, and pharmacists have the potential to be very much part of that narrative. Next slide, please. So, are these interventions cost effective? This is what, if countries think they are not cost effective. So we did this cost effectiveness analysis as part of our investment case for cessation 2 years ago. What we see is that the WHO recommended population level interventions, starting with brief advice, getting countries to put quit line solution, toll-free quit lines, or using text message programs, which have worked very well in some countries, are actually very cost effective. And we could potentially save, the 1.4 million is just in the next 4 years. And if you go into the whole life span of the tobacco users, it's more than 9 million lives to be. That's a lot of life saved. And the return on investment is like for $1, you get almost 3.5. But I want to also reflect on the pharmacotherapies, because you know the medicines. WHO's recommendations for varenicline, bupropion, and cytosine. Our clinical treatment guidelines are going to come out very soon, next month. All these medicines are going to be recommended. And what will it cost? And what's the ROI? It's nearly $1. So if you invest $1, you're almost getting $1. With some market shaping, we can actually make it more profitable. So that's something which we want to do in terms of shaping that market. And that's where the consortium, which Lars, you mentioned, Professor Ming mentioned that in my introduction, the consortium is designed to help that. Next slide, please. So what are we trying to do when we are getting into a formal statement? The objective of this statement is to help identify areas of work, which is very nicely outlined by Paul earlier. And in terms of what we are trying to do together, what are the specific elements which we believe that the pharmacist can help, not only just raising awareness or looking at giving brief advice, but looking into more specific areas of work. And that's what we have listed out. And so for us, it's an important element in the entire framework that we are getting a new set of stakeholders. I believe there are 1.4 million pharmacists. That's a lot of pharmacists in the world. How can we get all of them to support our work? So that's where we are trying to see common ground. Next slide, please. So I think the key word here is, how do we keep it sustainable? It cannot be that we make noise today, we have a statement, we go all through this exercise, but then we don't hold forth in terms of action on the ground. And I've been very much wanting to see that action on the ground, which is why we are hoping that the national level pharmacy associations engage with the national tobacco control programs, so that there's more collaboration. I'm aware of the lack of full engagement because I was in the government of India. In 2004 to 2009, I was the director of public health. And when I set up the National Tobacco Control Program of India, there was very little engagement with the pharmacy sector, pharmacists in India, which interestingly, India and Indians really depend on the pharmacists for the first advice. They're all there. So how do we get the best out of the pharmacists is where we would want to see in terms of collaboration at the national level. Next slide, please. So specifically, and again, I don't want to repeat all this, we would want to see, of course, all the pharmacists must be fully equipped with the knowledge of the harms of tobacco, which I don't believe everyone has. I mean, how many of us know that the tobacco use increases the risk of diabetes by nearly 40% for type 2 diabetes? How many of us know that it increases the risk of even developing cataract 1.5 times? We all know about cancer, cardiovascular, COPD, stroke, all of that. But do we really know the length and breadth of low birth weight babies? There's a whole range of problems. So we need to raise that knowledge. And then also, how many of the pharmacists know that if we get the tobacco user to quit, what are those gains which happen in the next 24 hours, next 15 days, next 1 month? Okay, cancer gains may not be there, maybe 20 years down the line, but other gains can come. We really need to pull that knowledge and get the pharmacists to understand. That's one. Number two is the right interventions. The tobacco industry is just wanting their next generation of addicts. So they're pushing new products, nicotine pouches, electronic cigarette, disposable vapes. There's a whole range. It's a daily exercise which we have with many countries to understand that what the industry has been doing. And one of the challenges has been in most countries, including high-income countries, is that the tobacco cessation, the adult who really wants to quit, sometimes believes there is not enough out there. So we need to share what is out there, what is recommended by WHO with all the evidence, and then find a way to get the pharmacists to engage and get the right medication, the right behavioral counseling measures recommended. I think that's an important point. And when I mentioned some medications, cessation, which is available in more than 15 markets, is over the counter in most markets. An important product which is going to be in the treatment guidelines of WHO. NRTs, we have just expanded the list of essential medicines list. It was from nicotine gums and patches. Now we've added mouth spray and lozenges. And then we've just pre-qualified the first NRT gum and patch from one big supplier, which was pre-qualified by WHO last month. So all this knowledge needs to go, and we are trying from our end to get the governments to know, because they also don't know, many of them, and then how we can create this engagement between pharmacists and tobacco control champions and program people would be what I would strongly believe a good success story if this statement has to come as a success, let's say in the next 1 year, in the next 2 years. Next slide, please. So from our end as WHO, we'll make efforts to engage, inform the member states, especially the tobacco control programs and the regulators of this statement. We convene the global regulators from almost 45 countries every year. And we just did that in Netherlands. So next April, we'll convene again, and we're hoping to do that either in one of the countries with huge presence, whether in the US or Australia. We're still figuring it out. So that is one option. And then, of course, through our regular networks and channels, because we have regional presence, we have our regional advisors. And then from FIP, and I'm hoping to seek more collaborative action as we've been discussing at country level. More specific country action. What are the specific country level elements which we can keep pushing? Not just in Jordan and India, but maybe pick another 3 or 4 countries so that we have some more global outreach and share all of this knowledge and seek an integrated approach. And that would help mainstream the pharmacy practice as well. And then jointly we can talk about the successes, the challenges, what we are going to be, if we have faced any, and how we can try and address that. And I think that would be an important element. Next slide, please. And that would be my end. Thank you very much for your patient listening. And I'm hoping to get some interesting questions during the panel discussion. Back to you, Lars, and our Professor Ming.
Thank you so very much for this interesting presentation. And I think it's so evident the huge impact tobacco cessation and nicotine cessation can have on health all over the world. Thank you so very much. It was a fantastic presentation. Now, next slide, please. Now it's my great honor and pleasure to present the FIP team that co-authored the new report, the FIP Global Intelligence Report on Pharmacist-Led Tobacco Cessation Services. We have Ines Nunes da Cunha, Practice Development and Transformation Projects Manager within FIP, Shirley May-Lianti, Data and Intelligence Specialist within FIP, and Farah Akkad, Data Integration Specialist within FIP. And I also want to acknowledge Marianne Favor Ongudi. She's an FIP intern and also a co-author of this report. Over to you, Ines.
Hello, my name is Ines Nunes da Cunha, and today, along with my colleagues Shirley and Farah, we are pleased to present selected findings from the FIP Global Intelligence Report on pharmacist-led tobacco cessation services. The full version of this report is only available to FIP members, but the pharmacist-led tobacco cessation services evidence of impact and country highlights version is available on open access. You can also have open access to the FIP Global Tobacco Cessation Survey Findings infographic. This report provides a comprehensive overview of the key role of pharmacists in tobacco cessation and how this contributes to timely patient care and to health system efficiency through interprofessional care teams. The report also shares global best practice to advance pharmacy practice and international standards of patient care. The basis for this report was established through a review of existing literature. In addition, survey and the compilation of country highlights specifically tailored to engage FIP member organizations were conducted. According to the 30 articles included in the literature review, tobacco cessation services or interventions provided by pharmacists are strongly correlated with health outcomes, economic savings, increased health system efficiency, and reduced burden on other healthcare sectors through interprofessional collaborations. Several studies included in our literature review suggest that tobacco cessation services are provided by pharmacists from different countries in community pharmacists pharmacies, and other primary healthcare settings, as well as in hospitals. The findings from the literature review demonstrate the impact of pharmacists' tobacco cessation services and highlighted their convenience and accessibility, their effectiveness, and their cost effectiveness. Several studies evaluated in the literature review highlight the global variation in the adoption and practice of community pharmacy and hospital-based tobacco cessation services, with an increasing number of countries promoting legislation and policies to enable the provision of such services by pharmacists and pharmacies. The literature review also identifies some barriers to the role of pharmacists in providing tobacco cessation services. Our findings suggest that legislation efforts to expand pharmacists' prescribing authority to include tobacco cessation medicines in some countries will increase the uptake of tobacco cessation services by addressing the barrier of obtaining a prescription from a medical doctor for the pharmacotherapy to be covered by insurance services. I will now hand over to my colleague Farah to show you some of the survey findings.
Thank you. Welcome, everyone. Today, we're excited to share the key findings from the FIP Global Survey that focuses on pharmacist-led tobacco cessation services. Our survey aimed to explore the variety of tobacco cessation services and interventions that are available, to examine the funding mechanisms and compensation for pharmacies, and to evaluate the cost-effectiveness of these services. In addition, it also aimed to assess the authority pharmacists hold in prescribing and dispensing medications and products that are related to tobacco cessation or reduction. So we gathered insights from 78 countries, which represent 75.3% of the global population. And our findings indicate that 65.4% or 51 countries currently offer pharmacist-led tobacco cessation services. This shows a substantial potential for the broader implementation of these services globally. Moving on, pharmacists are at the front line of direct patient education and public health initiatives. As you can see on the screen, in 84.3% of the surveyed countries, pharmacists actively provide advice on reducing smoke exposure. 76.5% of these countries engage in tobacco cessation awareness campaigns. And this shows the key role pharmacists play in increasing public awareness about risks associated with tobacco use and to promote available cessation strategies. Pharmacists also use a diverse array of techniques and models to support tobacco cessation, some of which are shown on the screen. These methods include the very brief advice, VPA, the 3 A's model, ask, advise, and act, and for those ready to quit, the 5 A's model. For the individuals not yet prepared to quit, there's the 5 R's model. In addition, we have the motivational interviewing, which is widely employed, focusing on empathetic engagement to encourage the cessation. And each of these models is designed to match the individual's readiness to quit, and this provides a tailored and personalized support. To improve the service delivery, pharmacists employ many tools, including the Figure-Strom test for the nicotine dependence, the stages of change assessment tool, and assessments of carbon monoxide concentration. These instruments are instrumental in evaluating nicotine dependence, checking the readiness to quit, and to confirm the abstinence. So using these tools optimize the effectiveness of cessation interventions to ensure that they're as impactful as possible. Thank you very much. I'll now hand it over to my colleague, Shirley. Over to you.
Thank you very much, Farah. Welcome, everyone. Let's now look at pharmacist intervention related to medicine access. Pharmacists play a crucial role in helping people quit tobacco. They guide users on nicotine replacement therapies, ensuring proper use and dose, and they also advise on non-nicotine medications such as ibuprofen. Their role is also expanding. As you can see in the bar chart, like the 24 countries and also 9 countries reported that pharmacies are able to prescribe nicotine replacement therapies and non-nicotine medicines to patients. If we are looking at the referral protocol of tobacco users, pharmacies are often refer tobacco users to other healthcare professionals. In 37 countries, pharmacies give verbal or written advice for seeking additional support. However, the standardized documentation is lacking. Only about 15 countries have established protocols for documenting written advice for referrals. In some countries, pharmacies also schedule medical appointments and communicate directly with doctors. This bridges a crucial gap in tobacco cessation support. One major barrier is the lack of remuneration for these tobacco cessation services, which limits pharmacists' ability to help more effectively. As can be seen in the bar chart on the right, 35 countries reported that pharmacies do not receive any payment for these services. A lack of supportive regulation and policies is also the major limitation reported by countries where pharmacies did not provide tobacco cessation services. So, supportive policies and financial incentives are essential to empower pharmacies in tobacco cessation efforts. As mentioned by my colleague Ines earlier, our literature review uncovered a lack of adequate training in tobacco cessation. This finding is also supported by our survey, where 22 countries identified inadequate training as a barrier. And we can see also over 3/4 countries reported that pharmacies do not need additional education or training for providing tobacco cessation services. The positive aspect that we found from our survey is that nearly half of the countries reported that some organizations or employers do offer relevant training courses for pharmacists in this area. In conclusion, pharmacies are a key in providing both medication and behavioral support for quitting tobacco. Legislative support, adequate pay, and proper training are vital to enhance their role. We encourage you to read further details about pharmacies' role in tobacco cessation in our report, which you can access through this link as well. Thank you very much for listening.
Thank you very much for the very interesting results. This shows so much more that we can do in order, and we have done so much, and also yet so much more that we can do to expand further the role of pharmacists in tobacco control. Okay. We now move on to our panel discussions. May I request all 5 panelists to switch on your camera, please? I'm very delighted to introduce our 5 panelists. Our first panelist is Mr. Raj Vadai, which is the ex-chairperson and vice president, India Pharmaceutical Associations at India. Second panelist, Mr. Wusam Al-Salamat, chairperson of Continuous Professional Development Committee at the Jordan Pharmacists Associations in Jordan. Our third panelist, Mr. Antonio Teixeira Rodriguez, Data Director, Evidence and Health Solutions, National Associations of Pharmacists at Portugal. Our speakers, Dr. Vinaya M. Prasad from WHO, Switzerland, and also our President of FIP, Mr. Paul Sinclair from Australia. If you have any questions, please feel free to post your questions on the Q&A box, which can help you to identify and read out. So let's see, maybe I'll get the ball rolling. Okay. maybe I could pose the first questions to our speakers, Dr. Prasad. I'm just wondering, so very interesting slides that presentation you have shown just now on the new statement, which all of us believe that is a very valuable tools to encourage the utilization of pharmacists for the provisions of tobacco cessation services. In your personal opinion, Dr. Prasad, how does this WHO plans to promote these utilizations of pharmacists both at the international or country level? Do you have any your insight about this?
Thank you. As I mentioned, it's very important to get national level engagement. And national level engagement is important for two reasons. One, that every country has its own unique challenges in terms of the socio-political, economic dimensions of engagement. So we need to see how this partnership can work better at country level. What are those conditions to engage well? And then based on that, we could use that as good examples of successes to push further engagement at regional level, at the regional bloc level, for example, in African and some of the Asian blocs. Globally, I'm sure if in your World Congress, when you're having a larger group of pharmacy associations and the national federations coming, it would be helpful to also find a way to engage, to understand, is this a real opportunity? What are those things which need to help create that real opportunity? And I think that's where we will have to think both globally, but I'm more interested in the national. Because for me, the proof of the pudding is national. If I don't get a national success, it's not very exciting to do global. So we have to work that out very quickly. So in the next 3 months, if we can show some good progress in any of the country, then we can use that as an example of success and ask other countries to also replicate in the Congress.
Okay, yeah, thanks for response, Dr. Prasad. Very interesting. I was just wondering, any response from representative from other countries, like for example, on the among our panelists, we have a representative from Jordan, India. Which, any specific information that you like to provide in your countries?
Would you like me to speak? So
Yes,
I would second what Dr. Vinayak said, that there are specific country responses that might differ based on the situation that the regulations allow for a response, whether it's by pharmacists or not, regarding the tobacco endemic, let's say. In Jordan, as pharmacists, we try to advocate for better health by making events that try to address the importance of quitting tobacco and trying to spread awareness by pharmacists for the community segments. For instance, for the Jordan Pharmacists Association, for last year, we initiated an initiative that is called a smoke-free generation, which is targeting school children. But the unique thing in this is that this initiative is led by pharmacists, is implemented by pharmacists, and we are visiting public and private schools in collaboration with stakeholders and partners. One of these partners is the FIP and the Ministry of Health in Jordan and the Ministry of Education. And we have a team of volunteers who are pharmacists or pharmacy students who we have equipped with a capacity building program that they can direct a specific message that is simple, proper for the age of the children, we are addressing, because in Jordan, as you know, the tobacco problem is spreading, whether it's smoking tobacco or smoking or vaping. And I would say there are other examples, but I would leave the chance for everyone to speak, and I will mention other examples later on.
Okay, thank you. Yeah, you did mention about vaping also. I think at the international level, it create quite alarming issues because this is currently the guidelines, different guidelines, and then the tobacco industry also keep innovating new type of products. Okay. So any other comments from the panels before we pose new questions? Okay. So there's one question from
Long
co-
Min, can I
Yes.
just add one question? Yeah, we have one question from the audience, and it's I think we should direct it to Dr. Binaya. It's from Boyamba Lamek. Government support farmers to cultivate tobacco, and we pharmacists are addressing tobacco cessation. How could we collaborate with the government to stop this while tobacco contribute the national finance via taxes paid by farmers and producers of cigarettes?
Thank you for that question. We ran a World No Tobacco Day campaign on grow food, not tobacco, very recently, right, last year. The year before, we ran a campaign called Tobacco Harms the Environment. And both are very linked. We have 80 countries, 80. The worst set of countries in that group are one high-income country called North Macedonia, right here. And then we have the countries like Zimbabwe, Malawi, Zambia, down south in Africa. The large tobacco growing economies are China, India, Brazil, Indonesia. And then Tanzania and these countries have started to grow tobacco because some high-income countries have reduced it. But as soon as we start documenting certain evidences, and I'll just give one example. We're running a project in Kenya, highly successful. And WHO just received the UN award for innovation last month, which shows that the narrative that tobacco growing is good for the economy and good for the farmer is a false narrative. But the industry is using it very effectively, and the governments have fallen prey to that narrative. So we went and told the Kenyan government that we'll help your farmers share, and they'll earn more income. They didn't believe it. I said, okay, let us do it. So we brought in World Food Program, we brought in FAO initially. We shaped the market. Good quality seeds, great market buying. And there was a story which was running in the Nairobi newspaper day before yesterday, that British American tobacco has to shell out now 40% more because leaves are not available. We have 7,000 farmers that shifted out of 35,000. 3 times more money growing beans, kidney beans, red kidney beans, high iron beans. So we can demonstrate that. The challenge has been that why do we have to wait for a WHO to come and demonstrate this? It's possible. So we really need enabling conditions and entities which are engaged in helping improve life outcomes of farmers, livelihood farmers, income, to also think of targeting the tobacco farmers. They normally stay away. They think the tobacco farmer is already happy farmer making more money, which is not the case. They're in a cycle of poverty and trap all over the world. Very few exceptions. In India, the Andhra Pradesh, and some of the states where they have making good money, but not all states. And I know that. In Bangladesh, and then the deforestation, the water table going down, air, land, soil pollution, all that is not even accounted for. So we are telling countries and raising awareness, and many of them are listening and asking for help. We have a request from Uganda, you have even a request from an island country called Fiji, which has a few hundred farmers growing tobacco. So raise awareness. I'm happy to share the links to all of this information so that the pharmacists can also talk about it.
Thank you so very much for your answer. Long Ming, do we have other country examples like from India or Portugal?
Yes, correct. So just to follow up what have been mentioned also, there's a new questions. So by James, there's the question is asking about the pharmacists are in the forefront of advocating tobacco cessations. However, while people do stop using tobacco, they tend to switch from using vapes. In this regards, what measure can we do as a pharmacist to address these growing concerns? So very specifically about the just have been mentioned also about vaping. Anyone would like to give your opinion about this? Specifically, or because as you know, the theme of this year World No Tobacco Day is protecting children from tobacco industry interference, which is also just mentions about the new products, smokeless tobacco or the vaping.
You want me to answer that?
Sure, Dr. Prasad. Yeah, please go ahead.
Okay, so what we have done in the last, we have issued a call to action on electronic cigarette in December last year with a good technical brief of whatever we know as WHO in the last 8 to 10 years in where the evidence lies in terms of the use of e-cigarettes. So now what we are seeing, first thing first, is that in most countries, almost all countries, the use of electronic cigarette is higher amongst children. It's not amongst adults, number one. Second, what we have seen is there are almost 50 to 60% dual users, which is more harmful. So they smoke and then they vape. Whenever they can't smoke, they go and vape. That's a huge problem. Third, we are seeing is that, which is switching, not quitting, because they are reducing their cigarette. But third, we are seeing is that those youth who start with e-cigarettes are more likely to become smokers. So electronic cigarette as an aid to help people quit is not, at a population level, is not demonstrated. What we are seeing is, of course, countries wanting to explore. So what the regulatory pathway is not to treat it as a consumer good. And the Australian pathway is the pathway. If you want to use e-cigarettes, then you want to create the regulatory pathway on a prescription only to adults, which is where Australia is moving, as one example. 35 countries have banned it. Having said that, we still need the adults to get support on cessation. And therefore, we are looking to see a scale up on, for example, cytosine. A lot of studies. It's showing 20% quit success. 20% quit success with one medication, which is in Poland and Bulgaria costs less than $65 for the whole treatment package. It can come down. In Canada, it may be $100 over the counter. In Australia, I think it's $200 for the whole package, treatment package of 25 days or something, and showing a 20% quit success. Same effect as varenicline, similar, quite similar. So so varenicline is very effective, but expensive. Cytosine is less expensive, should be promoted where available, and we're looking to see how we can shape the market. Now you've seen on e-cigarette, people who want to quit e-cigarette and addicted to it. Already some countries are starting to give license and approve, for example, nicotine mouth spray, this new product from Kenvue, available or licensed in UK and a couple of other countries, not still in the US. So these products are newer products. We even also now looking at trying to see how nicotine lozenges can be promoted. So, and trying to see not just gums and patches. We'll have to look at continuing to expand at whatever is available at a cost-effective price to help the smokers who want to quit and have quit to stay quit. Behavioral counseling works best. And therefore, that also we are pushing using tools. So we have now launched digital cessation tools. We are looking at digital chatbots. You know, the digital promoter, we call it Sarah, earlier used to call it Florence. That's also there. Then we have the chatbots in Viber, Messenger, WhatsApp. In Chinese, we have in the WeChat, which people can register and then log in and then get those messages. And it's very effective, almost like ranging from successes ranging from 12 to 19%.
Okay, very complete. Yeah, go ahead, Paul.
Thank you very much. Just very briefly, Dr. Vinayak alluded to the Australian scenario at the moment where they have banned the imports of all nicotine vapes. We had, in the space of 12 months, almost an epidemic in Australia of vaping, and not so much in older people, but in the younger cohort. It took hold very quickly and was causing significant problems in schools, amongst children as young as 8 to 15 years of age. The solution that they've adopted here is to ban it, and it will only be available on prescription through pharmacies. That seems like a good solution, but practically that will be very difficult. The TGA in Australia has only approved, I think at this stage, 2 formulations, and there is this burgeoning underworld marketplace now in nicotine vapes, which will continue to expand as the backlog of supplies is used. So there are real issues with that because the nicotine content of a lot of these is totally unregulated. The effects of the chemicals within the vapes is not fully established or understood. So that there is a significant issue here, particularly with the younger generation. So it's not only the smoking cessation, but the more imminent threat, particularly amongst younger people, as the next generation of nicotine consumers, is very much the vaping epidemic that we are seeing, which is a huge challenge, and maybe that's where pharmacists have a real role in education of particularly the younger people. That might mean partnering with departments of education and going into schools and providing services, education services to younger people. But I see the role, particularly with vaping for pharmacists, as one very much of including education and raising the awareness of the dangers of vaping.
Yeah, great points, Paul. I think Wissam, you raise your hand. And as well, Antonio.
Yeah, okay.
Go ahead.
Thank you so much for the really insightful information. I would just add for the situation here in Jordan regarding vaping. Until this moment, we didn't include or incorporate vaping as an alternative for smoking tobacco for now. We didn't accept that as a measurement for quitting tobacco. And I wouldn't say that we see a future that we would accept that as a method for quitting tobacco. But I would say that vaping, the main issue of vaping is that, especially in the younger generation, is that we sometimes discover that people in public places, regardless of the regulations, where public health measures are in place, where tobacco is banned in any public gathering, people are actually abiding by these rules. But when it comes to vaping, it's actually that they are bothered by the smell, not the harmful consequences of tobacco. So whenever someone is vaping in a public place, they perceive it as it's fine because the odor is fine and it's socially acceptable, and it's even dealt as an accessory. But when it comes to tobacco smoking, it's because of the smells, it's because of the visible consequences of smoking. So we end up dealing with the public having the perception that it's not about smoking, it's not about smoking in general, it's about being bothered by the physical and visible consequences of having this smoke out of your mouth. So vaping doesn't fit this category because people are justifying it's only a water vapor, it's acceptable, it has a nice odor, and we can have that in places. So we started to see signs where we usually have signs that there's no smoking in this area, there will be no tobacco smoking in this area, but vaping is acceptable. So, and this is really not regulated. It's just that the public is spreading this knowledge without having a baseline to come from. So not the community, not the regulators actually advised to spread these signs. Even in cafes or restaurants, they started to spread these signs so that people can shift into vaping, where places people cannot, let's say, object for the smell or have any bad experience for their stay.
Thank you, Usam. Can I also have examples from Portugal and India? And also, I see our two gentlemen have raised your hand. Antonio, what's your take about the smoking cessation services particularly at Portugal?
Yes, thank you very much. No, I just want to have that the situation in Portugal is similar to those already described, and what I wanted to point is exactly the point that you, Sam, made here, which is really important to understand to be able to develop effective interventions in this field. So the only thing I want to add is that in Portugal we have some medical societies and scientific societies doing several campaigns, like information campaigns, to give information to everyone about the risks of vaping and heated tobacco and the other new ways of smoking. But I'm pretty sure, and Paul already said that, I'm pretty sure that pharmacists can play a major role here on health promotion activities, health education activities, both with parents and adolescents. So we can actually, this is a very different way or pattern of smoking that we are dealing with, and we need to develop these new interventions to be able to implement them to pharmacists. And I think this is a very good opportunity to, again, impact on public health of the community.
Yeah, thanks. Very good response, Antonio. Just wondering also, Raj, in India,
Yeah.
we understand that availabilities of tobacco cessation services is limited. So how in your own opinion that we can increase the capacities and access to such services in India?
Yes, pharmacists are underutilized. Pharmacists are not trained or equipped to provide tobacco cessation services. But definitely it is very important, and we look forward to have that support and backing. Just beginning of this month, we're very fortunate to have the first training program for pharmacists. It's an active collaboration of the Indian Pharmaceutical Association, the National Pharmacy Association, with the support of the FIP and the WHO. So we are working on planning for more training programs, advocacy issues, and how we can take this forward so that pharmacists at a wider level can be trained so that they get the confidence and the support for providing these services. Now, just speaking a little about vaping, it's officially banned in our country, but available sporadically, sometimes from the internet. But we don't see that as a problem. Major problem that we have besides smoking tobacco is chewing tobacco. And that unfortunately even starts right from the childhood. Unfortunately, it's also used as a method to keep the child quiet, even the baby's quiet in some of the areas where the parents have to go to work. So it's a massive problem, and pharmacists have a good reach. We are about 0.8 million pharmacies in the country, and in large nooks and corners of the country where there is even no medical facilities available, there are pharmacists available. So that can be a good starting point, and pharmacists are definitely keen and ready to provide such service.
Okay. Thanks, Raj. I do believe that so much more and we can do together as a under the consortium. On that note, can we quickly come back to Paul again? Just wondering also from a FIP perspective, how can we best support and encourage our FIP member organizations and different individual pharmacists around the world to provide smoking cessation services?
Thank you. Yes. Obviously, this is something that pharmacists, we're speaking today about leveraging the capacity of pharmacists. Pharmacists are the most accessible primary healthcare providers in the primary healthcare space, and we need to encourage our member organisations to work with their members to actually allow that leveraging of that capacity to take place. We have seen very clearly in many countries the impact of accredited training on vaccination provision by pharmacists. So the importance of accredited training in providing both credibility and capability by the pharmacist in the local setting is proof positive that pharmacists have the capacity to deliver other services. We see that in many countries, vaccination, in many countries, disease state monitoring, point of care testing. Smoking cessation is just one more service. We will talk a little later on about barriers and enablers, but pharmacy is the best positioned primary healthcare provider to intervene to help with smoking or tobacco cessation. And it was very interesting earlier today, the health economic rationale of 21 cents US invested delivers a return of $3.58. I would suggest that there would be very few other interventions that could be delivered that would be such a positive health economic response. And I think that sort of information is what we should, through FIP and through our member organisations, be delivering to health bureaucrats and to policymakers to show the value of the pharmacist, to show how pharmacist interventions can save money, and to encourage politicians, to encourage policymakers to see the value of prevention rather than funding cures alone. Because if we can intervene, in Australia, for instance, a pack of cigarette, I understand, costs more than 50 Australian dollars for a packet of cigarettes. That's more than 35 euros. You would think that the easiest intervention of all would be the rationale of talking to a patient to stop spending more than 35 euros a day on something which is killing them. So there is a role for the pharmacist here, particularly with tobacco use. It is a lot of our patients who have other comorbidities, and the impact on their health, very few things can be done for these patients that will have a more immediate and a more positive impact than ceasing tobacco use. And pharmacists must be encouraged, and we need to be remunerated also to provide those services.
Yeah, I do agree with you, Paul. Any response or further informations from our panelists? Thanks so much, Paul. Yeah. We also have 2 questions on the Q&A board.
Can I just add
sure.
thing
Go ahead.
regarding the costs? Well, I know this is beyond pharmacists' role, but some countries' variation regarding the affordability of tobacco smoking has the major role of spreading tobacco. The case here in Jordan, as Paul said, the prices in Europe for tobacco smoking is actually very high, which is a measure for countering tobacco smoking. But in Jordan here, the average price of a pack of cigarette is around 1.5 or $2, which is very affordable for many people. So I would say that the average smoker would, let's say, spend around $5 per day if he smokes 2 packs per day. This is an affordable cost And the more that tobacco is affordable, the more people would go to that. And for vaping as well, there are vapes, there are coming versions of vapes where it is a disposable vape. You don't even need to maintain it. You just pick it up from the shelf and start smoking. And it costs less than $1. So these prices, regulations of these prices, if there are certain regulations that can try to maximize the cost and minimize the affordability of these products, I would say this is an acceptable measure, as we could see of the cost of smoking in North America or any other countries where the prices of tobacco is very high, that people try to question their intentions of tobacco smoking because they are considering their budget at the end of the month.
And any other response from specifically to response to some? Yeah, hi, Raj,
Regarding
go
the
ahead.
cost, while in India, a lot of things are cheap, including cigarettes. There is another version called BD, which is a little cruder version that is even cheaper, less taxed, and even worse is the chewing tobacco. It's very, very, very cheap and easily available, and that is a massive and a big nuisance across the country, because the other additional factor to that is that it has to be spit, and spitting is again an unhygienic situation where it spatters the buildings and street sides. But that is also another way for spreading communicable diseases, besides the other tobacco-related issues.
Cool.
Longming,
On that question,
can I ask a question?
Sure, please.
When listening to our panelists, in all countries, what would be the major drivers or barriers for the provision of tobacco cessation services by community pharmacists? If you can outline a short answer, the barriers or the challenges for the provision of tobacco cessation services. Antonio, please.
Yes, thank you. Thank you, Lars. Yes, I think I would like to add something. It's maybe a drive. I think it's a driver. And it's related with some of the things that some of the panelists already said here, which is, I think, probably one of the main drivers is the reimbursement of the service itself, whether by the NHS or any other payer. But particularly about this, how to develop a payment model that will recognize the added value that Paul and also stated, and we have seen in the previous presentations. We need to think about new payment models. Like it may be worthwhile to consider adopting a pay for performance or a similar approach in this context, because it is widely recognized or acknowledged that there's a significant clinical value in assisting these individuals to quit smoking. And by aligning the payment model by any payer primarily with this objective, the quit of smoking, it could potentially facilitate its implementation by payers. And I'm telling this because, for example, in Portugal, we know that pharmacies are already developing these services, but I'm pretty sure that if we have a structured payment model to recognize pharmacists doing it, it would be much better for the outcome that we want, which is having more people quitting smoking. And as a barrier, I would like just to emphasize one aspect, which is we had some slides with very important and relevant evidence already published. And we know that still probably is lacking some kind of evidence, or at least it was scientific evidence. I remember some systematic review from Cochrane where they acknowledge that the clinical and economic value of the pharmacist-led service, but they also acknowledge that more evidence was needed. And I think as a barrier, probably we need to know specifically for each setting which patients are more in which we are more effective doing pharmacist-led interventions in this field. And also there's a barrier in this evidence field, which is extrapolating results to individual settings, which can be challenging, highlighting the need for testing prior to offer decision makers the information that they need. And I would like to emphasize just these 2 points. Thank you.
Thank you so very much, Antonio. Rach, what about India?
Yeah, pharmacists are available all across, and they're very easy to access. So that is often they're also the first port of call for patients, and patients also have quite a lot of confidence in pharmacy. So pharmacists do provide their little inputs in regarding tobacco cessation, because they also happen to be one of the major points where NRT, gums and patches and lozenges are available. So that is also one thing, and the advice that they provide is also free, and they are available in a lot of patients come to them as first post of call. So that is also a good point for creating awareness. On the other hand, if you see the barriers that I had mentioned earlier, is that they're not sufficiently trained and not sufficiently confident to provide the counseling and even the treatment services. The other thing could be that there is a little lack of space. The pharmacies are relatively small, so there is a lack of space if we need to have separate counseling services in confidence. So that is another thing. Another thing may be specific to India and a few other countries, that many of the times in some of the places, the pharmacists are not there. That is also I see as a barrier.
Thank you so very much. Different drivers and barriers indeed. What about Jordan?
So I would say that there are similar barriers across countries, but I would say that one of the main barriers is regarding the shape of the pharmacy practice. And if we focus on community pharmacy, in Jordan, the way that pharmacies are designed, they do not account for a counseling area. So I would say that providing any pharmaceutical care service, whether it's tobacco cessation or other service, it needs a private space and a dedicated space where pharmacists can set and try to communicate messages regarding the health of the patients or the medications that they are taking. The other thing is that the barrier is the optimal knowledge. I wouldn't say that pharmacists do not have the knowledge. The knowledge is usually covered and can easily propagated by pharmacists and self-learning and checking all the publications and the resources available for tobacco cessation. I would say that the formal knowledge of a full service, that they do not have a full framework to provide a service in various settings. So publications related to the content and the scientific content for tobacco cessation would be helpful, but I would encourage more publications and more suggestions for a full service from the start to the end, and what are the specific messages pharmacists can do to practice a unique and optimal service for tobacco cessation. For the opportunities in Jordan, I would second my colleagues who said, Dr. Raj, that pharmacies are all over the country. We have 3,000 pharmacies, community pharmacies in Jordan, and they are pretty much accessible, free of charge, which is a barrier and a challenge. It's a barrier that pharmacists cannot commit to provide a service for free, regardless of our intentions and good intentions into influence the public health. But to make any service sustainable, we need modalities for reimbursements. The other unique challenge and opportunity, I would say, it's both, is that regulations of medications for tobacco cessation. In Jordan, there are two main categories for medications. The main category, one category is a prescription medication where you need to visit a physician to have this medication prescribed. And this fits the description for varenicline and bupropion. But it doesn't fit the description for NRTs, which we say in Jordan, it is an OTC medication, which is an over-the-counter medication. And this is the trick. This is the opportunity for pharmacists. And we try to always advocate for this idea, is that you can always try to recommend modalities of treatment without need for referral. But if the need for referral arises, you need to know the formal process for referral. In Jordan, we have, in the public sector, we have 29 tobacco cessation clinics across the hospitals and primary healthcare centers in the Ministry of Health. And we have some tobacco cessation clinics sporadic in some private sectors. And I believe that we are doing a good job in that regard, but we are not including pharmacists in these services. All of these clinics are operated by physicians, and the only way the patient interact with the pharmacist is when they prescribe when they try to get the medication from the pharmacy. And this is the only encounter where pharmacists can talk to the patient regarding the service. And usually it's just a handover medication and dispensing.
Thank you, Hussam. I think this also highlights the 3 C's, as I usually say: collaboration, collaboration, collaboration. So we need to find the ways, almost everything today in healthcare, to find ways of collaborate, because stronger we are, together we are stronger. I would say that it is evident that in response to the urgent need to help the over 1.25 billion global tobacco users to quit all nicotine and tobacco products, today's statement calls for a collaborative effort among healthcare professionals. And specifically, I think it advocates for national action to empower all pharmacists to routinely provide tobacco cessation support. And if every pharmacist identifies and advises just one tobacco user to quit each day, as we heard from our colleague from the World Health Organization, this collective action could reach over 4 million users in one single day. Isn't that fantastic? And the new intelligence report on tobacco cessation from FIP presents the findings of a literature review and a survey of FIP member organizations in almost 80 countries, shedding light on service availability, scope, funding mechanisms, remuneration models, and regulatory frameworks. It is clear that tobacco cessation interventions provided by pharmacists are strongly correlated with health outcomes, economic savings, increased health system efficiency, and also reduced burden on other healthcare sectors. So today is the day for accelerated actions. Think tobacco and nicotine cessation, think pharmacy. So by that, we can move to the next slide, perhaps. Yes. The recording of this episode will be made available on events.fip.org. And please provide your feedback on webinars@fip.org as well, so we can continue to improve our digital event offerings. And visit our events page as well, events.fip.org for future events. I would also like to shortly just announce the World Congress of Pharmacy and Pharmaceutical Sciences in Cape Town, Innovating for the Future of Healthcare. The potential for innovation in healthcare is vast and promising to revolutionize prevention, diagnosis, and treatment of diseases. So this is actually a fantastic opportunity for all those who are interested in designing the future of pharmacy and healthcare together to join us in Cape Town. And the early bird registration deadline is today, where we actually have the maximum registration fee discount. And here you can see the 3 tracks: equitable quality healthcare, innovative drug discovery and access, and revolutionizing healthcare with AI, as well as pharmacy, of course. So I would also like to recommend you to visit this program, and now a part of FIP Seal, where we have approved the program for this academy by the American College of Cardiology. to actually scan it and see how also this program can support us in advancing pharmacy practice, especially with regard to the NCDs. I would like to provide or give a very huge thank you to all our brilliant speakers today at the No World Tobacco Day, the World No Tobacco Day, where we actually have highlighted the role of healthcare systems working together with pharmacy to promote even a more healthy population worldwide, and also to improve the work of tobacco cessation as well. It's time for action, and we have all heard about the huge impact pharmacy can have when we are working together with our member organizations, the World Health Organization, and other national authorities. So thank you all for you who have been attending today or viewing this event afterwards. Now I hand over to my co-chair, Long Ming, for some final words. Thank you so very much.
Thanks. I would like to express my sincere gratitude and appreciation to all panelists and my co-hosts, and also the FIP organizer, and also all the participants. Thank you so much, everyone, for your kind participations.
And thank you to the FIP staff for wonderful technical support as always. Thank you so very much, everyone. And don't forget, today is the World No Tobacco Day, but it's also today for accelerated actions from pharmacists worldwide. Thank you so very much, and I wish you all a happy evening.
Thank you.